Thank you, Professor Rolfo, for your nice presentation. I think it's never too late. We have to continue. Not this session, but I'd like to thank the speakers, regional and guest speakers. I'd like to thank our co-chair. And I'll call for Professor Bellmunt and Professor Giselle Saad-Steve for the next session. Thank you very much.
Good evening, ladies and gentlemen. And now it's time for the keynote lecture powered by MSD. And this lecture will address the pivotal role of immunotherapy in treatment of metastatic urothelial cancer. And I would like here to introduce Professor Bellmunt, the Associate Professor of Medicine in Harvard Medical School, United States. Professor Bellmunt, a well-known figure in this domain, he was the past chairman of the Committee of Advanced Bladder Cancer in URTC. And in March 2013, Professor Bellmunt was appointed director of the Dana-Farber Cancer Institute Bladder Cancer Center in Harvard, Boston. Please, Professor Bellmunt.
Good afternoon. Thank you very much for the opportunity to share with you some of the recent advances in bladder cancer. So I know that everybody is pretty tired. I will try to focus my attention on what I need to discuss, and I promise that I will be on time. And if I can save some time, I will be more than happy. So my disclosures are going to be presented in one of the slides if they are coming. And the objectives, I need to present? I thought it was managed from there, okay. Sorry. Yeah, no, I think now it's there. Have it in my computer? Okay, here it is. So as mentioned, here are my disclosures involving several clinical trials of IO therapies. And the objectives of this presentation, I will quickly go through what is a standard of care in first line and in second line bladder cancer. And obviously this is to understand what's the role of immunotherapy in second and first line bladder cancer. I will review the phase 2 and phase 3 trials with PD-1 and PD-L1 inhibitors. And then I'm going to briefly mention, because you have received a lot of information about the future of immunotherapy, mainly in combinations and sequences. So this is a summary of what we have seen in bladder cancer for the last 25 years. Despite trying double therapies, triple therapies, new agents, nothing in fact changed since we got the MBAC combination chemotherapy in the early 90s. And it has been until 2014, 2016, and more recently 2017, where we have seen these new agents changing the paradigm and the way that we are treating metastatic urothelial cancer. So we know that standard of care first line is a platinum-based therapy, is platinum gemcitabine or platinum or MBAC chemotherapy. And what have been the options for therapy in patients failing first line chemotherapy? We have, in Europe and several countries, we have biflunin that has been used with 2.5 months in terms of survival benefit, limited benefit. However, this is the only drug approved in second line. We have learned a lot with biflunin because we have been able to know which are the prognostic factors in second line, and this is very important whenever you are designing clinical trials or whenever you are assessing what's going on with a new drug in second line, depending on the risk factors that are shown here, low hemoglobin, poor performance, or liver mets. You can see survivals in second line that can be up to 14.2 months if you don't have any one of these adverse prognostic factors, or your survival can be as short as 1.7 months if you have 3 of these adverse risk factors. So there has been several other trials in second line showing that bimflunin is there. This is a comparison of bimflunin with cabazitaxel. And then the only recent news on second line has been this paper that has been published this year in The Lancet. This is a trial that compared chemotherapy plus versus chemotherapy plus ramucirumab. And you know that ramucirumab is approved in second line lung cancer and gastric cancer. The endpoint of this trial was progression-free survival, minimal progression-free survival benefit, only 5 months, and still we are waiting for overall survival. So this is the only new stuff that we have seen in second line beyond the immunotherapy. What about the new treatment options? We have seen this slide so many times. So bladder cancer as lung cancer, melanoma, head and neck, has a high mutational burden, and this makes this disease sensitive to immune checkpoint inhibitors. And in GU malignancies, we have several approvals. This is shown here. This is a summary slide showing how crowded is the field. A lot of new agents, immunotherapeutic agents approved in melanoma, lung, Hodgkin lymphoma, renal cell carcinoma, head and neck. Metastatic urothelial cancer, as you can see, there are now 5 drugs that are approved. You can see here pembro, nivolumab, atezolizumab, and durvalumab, and avelumab. And also one important thing that has been already mentioned, it's we need now to consider the concept of MSI high. In general, whatever tumor that we see that is having this MSI high, it's eligible for immunotherapy. And this graph probably is outdated, so there are more and more drugs being approved in different spaces. But this is a summary of all the diseases that we can see are highly sensitive to different immunotherapeutic compound checkpoint inhibitors. So this is a summary of the 5 compounds that we have approved in the United States for treating bladder cancer. We have atezolizumab, that is a PD-L1 inhibitor, nivolumab, the PD-1, pembrolizumab, PD-1, avelumab, that is a PD-L1, and durvalumab is also a PD-L1. And that slide here is just to see that we are obtaining around 20% response rate with all these agents. And the median survival, as you can see, and those are trials, phase 1, 2 trials conducted in second line, we see that the median overall survival is a bit prolonged compared to bimflunin, to chemotherapy, but you can see here that the median survival is around 10, 12 months. Here, this is an exception in this trial showing a median survival of 18.5 months. And one important thing is that the progression-free survival is pretty short. It's even shorter than with chemotherapy. And we know with all these compounds that despite this low response rate, the patients that are obtaining response rate, the responses are durable, and this is the main benefit of immunotherapy in bladder cancer and in other diseases. This is the first paper that was published, and as you can see here, this was published in the Nature paper. It was 2014, and this phase 1 trial was accepted to be published in Nature because for the first time we saw outstanding responses in second line using immunotherapy in bladder cancer. In this paper, using the atezolizumab, a 45% response rate was observed in heavily pretreated patients. And this is a PD-L1 inhibitor, but then we have the PD-1 inhibitor, pembrolizumab, that in a similar trial, it was shown also to be effective in second line and beyond bladder cancer. You can see here response rate at 26%, different patient selections, but showing that immunotherapy was working in bladder cancer. And then we have seen several other compounds being studied in phase 2 trials. This is the phase 2 trial of atezolizumab, and this trial led to the approval of atezolizumab in the US initially, and also the subsequent approval in Europe. You can see here that the response rate in the second line, it's not 45%, and this is not what was seen initially in the Nature paper. It went down to 27%, similar to what is seen with pembrolizumab and other agents. And for atezolizumab, what you can see is that the importance of the PD-L1 expression, and this was seen in the phase 2 trial. Patients having high PD-L1 expression had much better response rate, and also they had much better survival. This is the phase 2. And this is, based on that, is made the atezolizumab people to do a randomized trial focusing on patients with high PD-L1 expression. As you can see here, the median survival of the whole patient population, 7.9 months. However, if you have a IHC 2 or 3, you can see that the median survival is 11.4 months. Other agents approved in second line, this is the Checkmate 275, nivolumab. You can see here, response rate 19.6%. Here again, if you have a high PD-L1 expression, it goes up to 28.4 months. This drug is approved. We don't have phase 3 data, but this drug is approved in second line in Europe and in the US in patients failing platinum therapy. Another agent that is already approved in the US but not approved in Europe is durvalumab. This is a paper that was published in JAMA Oncology. And here again, you can see that there is an enrichment in patients having high PD-L1 expression, as you can see here, 27% compared to lower response in patients not having or independent of the PD-L1 expression. The median survival is not reached in this phase 2 trial, and as mentioned, without having phase 3 data, this drug is approved in the States based on this data. Another compound that is avelumab, this is a Pfizer, a Merck compound, and you can see here, this is the paper that was published recently in Lancet Oncology, showing that the response rate is around 16%, and based on that, also avelumab is approved in the US, but not approved in Europe. So we have seen all of those trials are the trials that have been conducted in second line. Only those are single arms, phase 1 or phase 2 studies. But the question is, how can we know that these agents are superior to chemotherapy? Presently, we have 2 phase 3 trials that have been conducted in second line comparing immunotherapy with chemotherapy. The first one is the Keynote 45, and you can see here that the trial design patients randomized to receive pembrolizumab, that is a PD-1 inhibitor, or the standard of care chemotherapy, that could be paclitaxel, docetaxel, or bimflunin. The primary endpoint of this trial, overall survival, progression-free survival, secondary endpoints, overall response rate, and safety. In a similar way, the IMvigor 211, they designed this trial where you can see is a phase 3 randomized trial. More patients in this trial, 932 patients randomized to receive atezolizumab or a standard of care, and this was driven by the physician. Patients could receive chemotherapy based on docetaxel, paclitaxel, or bimflunin as here in Europe. So what about the results of the phase 3 trial, the Keynote 45? You can see here again the design. Those were patients that failed platinum-based therapy. They could have received 1 or 2 lines of therapy. One important thing, those patients were carefully stratified, and this is based on the prognostic factor paper that I mentioned that was based on bimflunin. Stratification was based on good performance status versus poor, 1, 2 versus 0, 1 versus 2, low hemoglobin, liver mets, and also we included a factor that is the time from prior chemotherapy. 542 patients were randomized to pembrolizumab or paclitaxel, docetaxel, or bimflunin. The primary endpoint, overall survival and progression-free survival in the overall population, and also in the patients having that score CPS, that means a composite positive score of more than 10%. The results of this trial were published in the New England Journal in March this year, and obviously whenever a trial is published in the New England means that this trial is positive, and as you can see here, the results of this trial are shown here. So the median survival in patients receiving the pembrolizumab was 10.3 months, compared to 7.4 months in patients receiving chemotherapy. And as you can see here, the hazard ratio is 73%, so a 27% reduction in the risk of death with a p-value of 0.0022. The same was seen in the population of patients having the CPS score more than 10%, though in those patients, and this is interesting, that the median survival was inferior, despite that there was a statistically significant difference between immunotherapy and the chemotherapy. You can see here that the hazard ratio is still much better. However, the median survival is 8 months versus 6.2 months, and this is a matter of discussion that we can discuss later. So about the PFS, we know that the PFS is not a good endpoint for all the immunotherapy compounds. And you can see here no difference in progression-free survival comparing chemotherapy or pembrolizumab. And as you can see, even the PFS is even shorter in those patients receiving immunotherapy. And one interesting thing that we need to know is that it takes a while until the immune system is setting up an immune response. And as you can see here, pay attention on this very beginning part of the curve where the survival in the first 2 months, 2-3 months is inferior for the immunotherapy compounds. That means that patients who have a quickly progressing disease, they probably might require another therapy and not immunotherapy. However, in the end, it has a ratio, you can see that subsequently improves the outcome when in patients receiving immunotherapy. So what about an important thing is the side effects, and you can see here that in blue you have the side effects that are related to chemotherapy, and it's easy to see that the side effects were superior in patients receiving chemotherapy compared to patients receiving immunotherapy. And as expected, if you focus specifically on immune-related side effects, meaning those that are derived from the immune mechanism of action of the drug, you can see that more thyroid abnormalities, more pneumonitis, more colitis compared to chemotherapy, as we might expect. So important to mention that still, although we see the frequency of pneumonitis is less in patients receiving PD-1 inhibitors compared to CTLA-4, for example, you can see here still that some patients can develop a pneumonitis. And it is important to recognize this side effect because this was superior when compared to chemotherapy, although this was treated in general successfully, and only one patient died due to pneumonitis during this trial. So we have seen this first phase 3 trial that has been positive, showing that immunotherapy is superior to chemotherapy. And we have mentioned that there is this second trial, the IMvigor211, where patients were randomized in a similar way to receive atezolizumab, that is a PD-L1 inhibitor, versus chemotherapy. And here the primary endpoint was overall survival. So here you can see, this is taken from the press release, and now the paper is published in The Lancet. Patients were randomized to atezolizumab versus chemotherapy. One important thing, the main endpoint of this trial was overall survival test hierarchically in pre-specified population. And because of the results coming from the phase 2 trial with atezolizumab showing that patients having PD-L1 positivity had much better survival, the endpoint was overall survival in patients being PD-L1 positive 2+ or 3+. And here you can see the results of this overall survival analysis in this, and IC means immune cells to 3 population. You can see here that the survival for atezolizumab, the median survival was 11.1 months, and this is what has been seen in the phase 1 and in the phase 2 trial, so as expected. However, we can see here that the chemotherapy, in fact, outperformed, leading to a non-statistically significant difference. So this trial was, in fact, negative when comparing immunotherapy versus chemotherapy. There are a lot of hypotheses here, but the fact is that despite atezolizumab doing its job, the trial was negative. Despite that, the atezolizumab is approved in the States and also in Europe, based on mainly on the consistent results seen in the phase 2 and also in this phase 3 trial. And as you can see here, also in the overall population, still there is a trend of significance. However, this was not the primary endpoint. So atezolizumab is an effective drug. However, based on this phase 3 trial, the results were negative. So we have been discussing mainly second line and mainly patients who receive platinum-based therapy. But we know that in bladder cancer, metastatic urothelial carcinoma, we have a population of patients who have poor renal function, and where in the metastatic setting, those patients are not eligible for platinum-based therapy, and we usually treat these patients with carboplatinum and gemcitabine. So based on that concept, one of the things that has been done is to explore the role of immunotherapy in first-line, previously untreated patients who are not eligible to receive platinum-based therapy, that is the standard of care. And you can see here the results of the 2 trials that have been conducted in first line using immunotherapy as a single agent. You can see here the atezolizumab trial, the pembrolizumab trial. This one based on 119 patients. You can see here response rate in first line 23%, median survival 15.9 months. And this is obviously a very good survival because we can see that the median survival in patients receiving first-line carboplatinum-based therapy is only around 13 months in the best of instances. For the pembrolizumab, similar results. The trial is larger, 29% response rate, and we can see here that the median survival has not reached, so this trial is a bit immature, but based on these 2 trials, these phase 2 trials, atezolizumab and pembrolizumab are now approved in Europe and in the US to treat first-line patients with bladder cancer who are unfit to receive platinum-based therapy. Here are the results of the IMvigor 210. This is one of the arms of this, the phase 2 trial in patients who are unable to receive platinum-based therapy, and you can see here the survival of 15.9 months in patients receiving atezolizumab. And here is for the atezolizumab pembrolizumab trial in first line. This is the Keynote 52. The paper has been published this year in November 2017. And you can see here in this group of patients having the combined positive score of more than 10%, and this is based on the PD-L1 staining. The response rate is 37%. So pembrolizumab is an obvious option for treating patients in first line and patients who are unfit for receiving platinum-based therapy. So this is the results we have. So presently we have in the US 5 agents approved in second line. In Europe we have approved atezolizumab, pembrolizumab, and nivolumab. In patients who are platinum ineligible, we have pembrolizumab and atezolizumab. So 2 drugs, and those agents are approved in Europe and in the States. And obviously, we are trying to improve the outcome in bladder cancer patients, and what has been done is to start exploring immunotherapy in different disease settings. We have mainly seen all these trials in second line or in first line. However, now there are trials exploring earlier, meaning using immunotherapy as in the neoadjuvant setting, and even atezolizumab and pembrolizumab are being explored in patients having non-muscle invasive disease, those who are BCG refractory. And these trials are accruing well. We still don't have results. And obviously the future is select patients with biomarkers and obviously use combinations, as has been mentioned for lung cancer sessions before. And here you can see the 4 trials that are presently being analyzed. There is one trial that has been close to patient accrual, that is the DANIEF trial, shown here, where immunotherapy is being compared to dual combination immunotherapy versus chemotherapy. Or we have the Keynote 361, that is a trial where in first-line patients who are platinum eligible or platinum ineligible, the immunotherapy is being compared to the combination of chemoimmunotherapy or versus chemotherapy. So all these drugs, you can see here, this is the pembrolizumab trial design in first line, the atezolizumab trial design in first line. This is the durvalumab. This trial has been completed. This is the one that we are going to get the results pretty soon, hopefully before 3-4 months. And then obviously nivolumab is being studied in combination with ipilimumab, as we have seen in lung cancer, in first-line therapy. So we are moving earlier and combining the PD-1 inhibitors with other checkpoint inhibitors like CTLA-4 or with chemotherapy. And as you have seen, this is a similar way of analyzing immunotherapy as has been done in lung cancer and other diseases. So what about an area where we know patients sometimes require therapy? And this is for maintenance. And we know that in lung cancer, we have the pemetrexed trial showing that in patients who obtain a good response to first-line therapy, continuing giving chemotherapy is a good option and prolongs progression-free survival. A similar design has been done for bladder cancer, and as you can see here, this is the Javelin trial where patients, after having received first-line chemotherapy and obtaining a response, instead of stopping therapy after 6 cycles, patients are randomized to receive bellumab as maintenance or their supportive care. This trial is accruing and is going to tell us if maintenance immunotherapy, as we have seen in the Pacific trial for lung cancer, but here we are not using radiation therapy, is going to be of benefit in patients receiving first-line chemotherapy and obtaining a good response. And then, obviously, as mentioned, the field is moving to combination and moving to combination plus personalized approach. We have seen presentations looking for potential targets for intervention with immunotherapy, and obviously combining immunotherapy plus targeted agents is an option. Here is an example of a trial that is named BSky, where patients are being genomically profiled. And as you can see here, based on the profile that we obtained, the genomic profile, we are using a different combination. This is, for example, durvalumab is being combined with an FGFR3 inhibitor in patients having FGFR3 mutations. In patients having DNA repair mutations, durvalumab is being combined with olaparib, or in this case, patients with having mutations or CDK4 mutations are being combined with this compound that is a CDK4 inhibitor. In patients not having any one of the mutations are receiving durvalumab, so based on the genomic profile, patients are receiving either monotherapy or durvalumab, that is a PD-L1 inhibitor plus a targeted agent. And I think this is the way to move forward. As you can see, this is a really small trial design trying to pick the winner and drop the loser. And hopefully, this is going to shed light on the way that we need to combine immunotherapy with targeted agents. And then the only data that we have that has been reported in bladder cancer is the combination of pembrolizumab with epacadostat. This has been mentioned before. Epacadostat is an IDO inhibitor that is involved in the tryptophan metabolism of the immune cells. And as you can see here in this trial, that was a randomized trial a phase 2 trial, but randomizing to different treatment options, you can see that combining pembrolizumab with epacadostat, the response rate observed was up to 36%, and in patients being PD-L1 positive, the response rate went up to 60%. So it could, and now this combination is moving to the phase 3 trial in first and in second line. So it seems that the pembrolizumab plus the IDO inhibitor is one of the best combinations to explore in bladder cancer. And as mentioned, phase 3 trials are presently accruing. Other options, other trials that are being conducted, obviously, is combining PD-1 inhibitors with CTLA-4 inhibitors. You can see this is results coming from the phase 2 that was presented at SITSIC. We can see that this is doable, feasible. We can see that the median overall survival is not that exciting, but probably is because those patients are heavily pretreated. Meaning that the field is moving forward, and as mentioned, this combination is now being tested in first-line phase 3 trial patients who are treatment naive. So how we can see now the bladder cancer field, we have seen that it was till 2016 nothing happened, but we got in 2016 approval of 5 immunotherapeutic compounds as monotherapy in second-line bladder cancer. In the US, deslizumab was approved in first-line and also pembrolizumab, and presently we can see now the EMA has approved pembrolizumab in second-line and in first-line. Nivolumab is approved in second-line. Atezolizumab is approved in first-line patients who are unfit and in second-line. So after 25 years of nothing changing, now we have